Professor Peter Nilsson.
Thank you very much for the kind invitation to join your meeting this afternoon. My name is Peter Nilsson. I'm a professor of clinical cardiovascular research at the Lund University in Sweden. Today I'm invited to talk about novel perspectives on lipid treatment, guidelines, efficacy, and combinations. I think you are well aware of the importance of lipid control to combat cardiovascular disease, but I will talk about some new guidelines, some new findings, and the importance of combination treatment. I have no specific disclosures for this presentation, and according to the recommendations of my university, this is the third task, so-called third task, to reach out, to give lectures and have a dialogue with colleagues, etc. So we have a lot of unmet needs, lack of compliance, and also the problem of LDL cholesterol variability to discuss. And I will start with this slide to indicate the lack of adherence to our treatment. Many of you prescribe lipid-lowering drugs. However, according to some reviews, about half or even more of patients are non-adherent to statins after 1 year. Of course, there is a difference whether there was a previous CVD event, because then people are more motivated as compared to primary prevention. These figures can improve by use of motivation, by use of regular contacts, and by using simplified treatment, for example, fixed combinations. I work very much in hypertension, and recently we have seen the rise of the fixed drug combinations in antihypertensive treatment, because it makes life so much easier for our patients. So if people are not in adherence, the risk of a CVD event or CVD mortality is increased, as shown on this slide. Unfortunately, a minority of our patients are at goal for control of LDL cholesterol. Even with the best treatment options, there is a lack of reaching the goal in many patients. And according to this review, only 1/5 of the patients reach very low goals. And as you know, recent guidelines both from Europe and the United States indicate and recommend lower LDL cholesterol goals for patients at risk, especially with a previous cardiovascular event. We should also recognize that survival is lower if people are not on treatment, because the motivation may wane after a few years if we not repeat our message that LDL cholesterol is important, that taking the drugs is important for the patients. And I think motivation is everything. In Sweden, we use also skilled nurses to assist the physicians and to repeat the message and to provide some guidance and teaching for the patients, including the spouses, because if we can reach the spouses, they can also make the patient more compliant to the drug intake. A new topic is LDL cholesterol variability. And as you can see here to the right of the slide, there is proof that increased LDL cholesterol variability is associated with increased risk of death, cardiovascular outcomes, and serious events. This means that if we can have a very good LDL cholesterol control by, for example, fixed combination, there will be lower LDL cholesterol variability, and that will reduce the risk. So it's not only the mean LDL cholesterol level that matters, it's also LDL cholesterol variability that should be improved. We know that we have several statins because that is the most widely used kind of drug for lipid lowering. We have other drugs. We have very expensive drugs with the new PCSK9 inhibitors. But as you know, high intensity statin therapy may reduce LDL cholesterol around 50%, but that is based on the fact that the patient is compliant. If the patient is not compliant, the effect will be, of course, lower. So to your right, you have moderate intensity statin therapy, but to your left, you have the high intensity statin therapy, including Rosabastatine. That is perhaps the most potent statin available today. In some patients, we see familial hypercholesterolemia that varies in different countries. In some parts of the world, the prevalence is rather high as compared to some other areas. But if we diagnose familial hypercholesterolemia based on symptoms, based on blood sample analysis, we have to lower LDL cholesterol much more intensively as compared to some other patients. Now I turn to the 2019 European Society of Cardiology, European Atherosclerosis Society guidelines to treat dyslipidemias. There are also corresponding guidelines from the United States. I will come back to that. But as you see from the list of authors, there are also American authors added to this list of authors, also Swedish authors. So when we use millimole per liter, in Sweden you use milligram per deciliter, but you can recalculate that. The message from the new guidelines is that LDL cholesterol is the most important primary target, and the new target goal for very high-risk patients is 1.4 millimole per liter, or a 50% reduction is also acceptable for increased LDL cholesterol. But in patients with high or very high risk of CVD, using the highest tolerable dose of statin, there is a case for a combination with Ezetimibe, that is a cholesterol absorption inhibitor active in the gastrointestinal tract. And in some rich countries, the new, very expensive drug PCSK9 inhibitor is also available, but in my country, just a very few patients are treated with that because of the high cost. So if we take a closer look at the recommendations in secondary prevention, patients at very high risk should have this LDL cholesterol reduction I told you, with a goal 1.4 millimole per liter or 50% reduction from baseline, with a very high class and level of evidence as indicated on this slide. But of course, this is most often not possible by monotherapy alone. You have to use combination treatment. Well, if we consider patients with atherosclerotic cardiovascular disease in their history with more than one vascular event, we have to aim at even lower goals for LDL cholesterol. So with the repeated myocardial infarction, we have to do even better with control of LDL cholesterol, as seen here. There are patients at moderate risk or lower risk. We can have more flexible goals, but for the real high risk or very high risk patients, we must be more ambitious, do even more. So you should know your patients, you should try to stratify according to risk. And for the very high risk patient, we have to do better. There is a change in the guidelines as indicated here from the previous 2016 guidelines. Now the combination with ezetimibe is recommended if the LDL cholesterol goal is not achieved. So there is more evidence to use ezetimibe as add-on drug, and in some cases with statin intolerance, ezetimibe or other lipid-lowering drugs has to be used alone. Other messages from the 2019 guidelines are indicated here. In secondary prevention with patients at very high risk, we have to combine statins and ezetimibe and even the new PCSK9 inhibitors in countries where that is available. Also for the very high risk FH patients, we need combination treatment, and in some selected cases, also PCSK9 inhibitor treatment. Another case is hypertriglyceridemia, when statin treatment is recommended for individuals with more than 200 milligrams per deciliter of triglycerides. In patients with acute coronary syndrome, we need to also combine statins with ezetimibe and in some cases add on injection therapy. Another slide to show you the level of evidence for these recommendations. You can see here that if goals are not achieved with a maximum tolerated dose of statin, the combination with ezetimibe is recommended with a very high level of evidence. We need to do much better. The evidence is always expanding because new studies are published, but at least for now, we can trust these guidelines from 2019 to be updated and useful to use. In a few cases, we can also use other drugs if statins are not tolerated. But as you can see from this slide, the evidence base is less solid. There are fewer studies. Now I turn to the combination treatment more to have that more in focus. And from this slide, you can see that combining a high intensity statin plus ezetimibe can lower LDL cholesterol around 65%. And that is almost as good as using a PCSK9 inhibitor plus statin and ezetimibe. I think that in a country like Pakistan, you can very well use high intensity statin plus ezetimibe to control your high risk patients. We are doing the same in Sweden. We also learn from recent guidelines that the lower is the better for lowering LDL cholesterol. There are no serious side effects. We also know from genetic studies that people with a genetic mutation to provide them with a very low LDL cholesterol throughout their life are at low risk with no serious adverse effects. So the message from this slide is that the higher the risk, the lower we should go for LDL cholesterol control. And you can see to your left the goals both expressed in millimoles per liter and milligrams per deciliter that you are perhaps more used to. What about diabetes? I deal a lot with diabetes patients, and here we have very solid evidence to recommend the tough goals of LDL cholesterol less than 1.4 or less than 55 milligram per deciliter, very high risk patients, or less than 1.8 or 70 milligram per deciliter in high risk patients. Statins are of course, the number one drugs for these patients. Even if statins can also increase fasting glucose a little bit, that is overshadowed by the benefits on the cardiovascular system. And also for patients with diabetes, statin combination with ezetimibe is very useful because many of these patients do have cardiovascular manifestations. Sometimes they have experienced even silent myocardial infarction, and this is visible on the ECG. They didn't know about it, but you as a physician can diagnose that when you take an ECG and you scrutinize that. So looking now for uh, standards of medical care in diabetes, the American guidelines from the American Diabetes Association, I just show you a few slides because they recommend that a full lipid profile is important to have at the time of diabetes diagnosis, and you should repeat that every 5 years, at least, maybe even more often, to tailor the right therapy to the right patient. Statins are, of course, very often used, and if that is not sufficient, you have to use combination treatment. So on this slide, stating primary prevention using statins for patients with diabetes, you can see that high intensity statin therapy is recommended for many of these patients. And for the real high-risk patients, it may be reasonable to add ezetimibe to maximally tolerated statin therapy to reduce LDL cholesterol levels by 50% or more. So this is highlighted in the most updated American guidelines. For secondary prevention, there is also a case for intensive LDL cholesterol lowering, and one may use ezetimibe in many of these cases because PCSK9 inhibitors are too expensive to use. Now I turn to rosabastatine as the most effective statin that we know. It can be used as mono or combination treatment. I think you know about the HOPE-3 trial published a few years ago. The principal investigator was Professor Salim Yusuf, born in India, now living in Canada. And the HOPE-3 trial recruited medium risk patients all over the world. And it was shown that treatment by use of rosabastatine versus placebo reduced LDL cholesterol, ApoB, but also markers of inflammation. The primary endpoint was successfully and significantly reduced by having rosabastatine versus placebo, and that was also true for coronary heart disease and stroke, as seen on this slide. Safety was good, no serious adverse effects, but one remarkable thing was that permanent discontinuation was in fact more common in the placebo group than the rosabastatine group. So I take that as an indication that the drug was well tolerated in spite of some muscle pain weakness in a few patients. A sub-study of the HOPE-3 trial looked at Asian patients because almost half of the patients recruited for HOPE-3 came from countries in Asia, many from China, India, and Korea, etc. And on this slide, you see that there was a very pronounced beneficial effect on stroke. in the Asian patients, maybe even more pronounced than in non-Asian patients. So this is something we should take into consideration, that lipid control could benefit also stroke prevention in Asian patients. One interesting observation was that the side effects were less common in Asian patients than in non-Asian patients. I take it as an indication that rosabastatine was rather well tolerated in the Asian patients. I do not have an explanation for this, but I think it makes sense to know that they were well tolerated. Ezetimibe, as you know, inhibits sterol transporter at brush border in the gastrointestinal system, and that will turn off the intestinal absorption of cholesterol and lower levels of cholesterol. A very beneficial effect, very few side effects, because this drug is locally active. In a recent review, the combination of these two drugs, rosabastatine and ezetimibe, were compared. On this slide, you see some data about the mechanism of action of these drugs and the lipid-lowering effects. So both are lipid-lowering, but in combination, they are even more effective. I mentioned previously that rosabastatine is currently the most effective statin that we know, and it can be combined effectively with ezetimibe, according to this review. The take-home message from the review is indicated here. It's possible to combine two lipid-lowering agents with complementary mechanism of actions. The fixed drug combination bioequivalent to the separate agents, and significantly more effective than monotherapy to reduce LDL cholesterol and even total cholesterol. And finally, this is generally well tolerated. On this slide, you see the additional effects of adding ezetimibe to statin therapy. So when you compare the effects of high-dose statin alone with the low-dose statin plus ezetimibe, that is comparable. But if you use a high-dose statin with ezetimibe, the effect will be even more pronounced and beneficial. Here you see different dosages of rosabastatine plus ezetimibe from analysis from one of the trials. And the message here is that the combination can be even more effective than rosabastatine alone. From this trial, it was shown that this combination, rosabastatine and ezetimibe, reduced LDL cholesterol, total cholesterol, and triglycerides. But on the other hand, HDL cholesterol was increased. A Spanish study could show similar effects. The red arrow indicates that the combination of rosabastatine 40 milligram plus ezetimibe had the highest effect on LDL cholesterol reduction. Coming soon to the end, this study from Poland compared a morning intake with an evening intake of this combination rosabastatine plus ezetimibe with a similar effect. So it doesn't matter whether the drug is prescribed to take in the morning or in the evening, the effect is the same. So, in summary, there are many unmet needs in lipid treatment, as I told you about lack of efficacy, lack of adherence, and some patients not reaching treatment targets. This could be uh, an indication of insufficient motivation of the patient or less useful drugs because uh, fixed combination drugs could make the intake much easier, less easy to forget about one pill as compared to two pills. So we should also encourage ourselves and our colleagues to read the guidelines and try to reach the treatment targets because these are evidence-based. High-dose statins should be used for high-risk patients, often in combination with ezetimibe. This is a drug active in the gastrointestinal tract, very well tolerated. In the HOPE-3 study, we had evidence from primary prevention in medium-risk patients benefiting from rosabastatine versus placebo. And as I mentioned, in Asian patients participating in HOPE-3, there was a pronounced stroke preventive effect. And finally, the combination of rosabastatine plus ezetimibe has been proven to be effective to reduce LDL cholesterol irrespective of morning or bedtime intake. Thank you very much for listening.
Okay. Thank you so much. It was a wonderful presentation, which probably cardiologists and endocrinologists both were interested in. And as you know, the statins is close to the hearts of cardiologists, not only cardiologists, but endocrinologists as well. So we have time for the question answers. Any question and answer?
Thank you, Professor. It was wonderful discussion. And regarding the efficacy, it's good, as you have shown with the slide. I'm just concerning about the GI tolerability effects of these Ezetimibe when you are combining with Rosabastatine.
Please repeat.
Yes, GI tolerability effects because it's affecting on the brush borders of the intestine. Is there any chances that
The brush border effect. To my knowledge, there is no harmful effect because ezetimibe, its effects is continuous. There will not be a lack of effect after some time. So I think we can safely use this combination.
Any other question?
Would you please recommend at what cholesterol level or LDL level we should start a statin? The ezetimibe is only used when we need a very high response. In a common patient, usual patient, at what level we should add a rosuvastatin or a atorvastatin?
Experienced physician, many of you see patients for secondary prevention because they already had myocardial infarction or a stroke. And then, of course, they are high risk or very high risk patients. They should go for high intensity statin in the first place. You have your own experience and don't hesitate to have a high dosage, high intensity statin. Then it can also be combined with ezetimibe if the goals are not reached. I think we should not rely only upon one measurement of LDL cholesterol. You know as physicians that we need repeated measurements to have a better picture because there could be some fluctuation. Please remember, I told you not only about a fixed goal, but also that a 50% reduction from baseline is good enough. So many of the patients, they start with, let's say, 3, 4, or 5 millimole per liter of LDL cholesterol. And of course, we should aim for the low goals, 1.4 in the very high-risk patients or 1.8 millimole per liter in the high-risk patients. But if we are successful in reducing 50%, we should also be happy by this. But my message is really don't trust a single measurement of LDL cholesterol. Please take repeated samples. And please also consider whether there is a hepatic disorder, a renal disorder, or low thyroid function, because these organs can also influence cholesterol levels.
Thank you, Professor Nilsson, for excellent talk. As an endocrinologist and metabolic physician, I'm always intrigued by the use of statins and then using on top of this ezetimibe, which obviously reduces the absorption from the gut. And the combination of that and what we are seeing is an epidemic of vitamin D deficiency. I just wonder, does anything has to do with the use of a lot of statins and fat-soluble statins and the ezetimibe, if you're comparing? Does it have to do anything, or does it affect vitamin D in any way?
Well, not to my knowledge, provided that the vitamin D intake is normal and sufficient in the first place, because in the large randomized controlled trials, I haven't seen any indication of vitamin D deficiency. However, in some countries, we have less sunshine, like in Sweden. You have much more sunshine in Pakistan. And of course, when people move from your country to Sweden, and if they use the veil or clothes to protect them from the sun, we see vitamin D deficiencies in Sweden, we do. But I cannot blame statin and ezetimibe treatment for that, not to my knowledge.
It was an excellent talk. We enjoyed it a lot. Thanks for updating us on all the guidelines. My question to you is that adding ezetimibe does bring LDL and total cholesterol down. How does it, does it affect triglyceride at all or not?
Well, I think statins lower triglycerides. Fibrates can also do it, but fibrates are less used these days. I don't think there is any specific effect of ezetimibe on triglycerides. It's not mentioned in the guidelines. But of course, you know that impaired glucose metabolism is a driving force behind hypertriglyceridemia. So in such patients, you should, of course, try to investigate glucose metabolism. Maybe prescribe an oral glucose tolerance test, or to do some other measures, because in prediabetes, impaired fasting glucose, impaired glucose tolerance, many people have high triglyceride levels. In countries with alcohol intake, like in Sweden, unfortunately, a high alcohol intake can sometimes also increase triglycerides. So we have to find out about that.
Excuse me, I also have a question there. I
Oh.
am a practicing nephrologist, and your talk was very educative, and it was very nicely given. But sir, I want to ask that in our practice, we have usually seen that our population, they don't tolerate very high dose of statins, and they have this complaint of muscle aches and pains, and that complaint is even more in CKD patients. So usually I usually see those guidelines that 40 to 80 milligram of atorvastatin, but we are unable to give such a dose, and there is a problem of muscle aches and pains. And I was seeing that you were showing that that has been tolerated well in Asians. But what our clinical experience is that we have to give a lower dose of statins because of that aches and pain. And sometimes we have to add coenzyme 10 to reduce that problem as well. So one was this, and in CKD patients, they are even more prone to develop that muscle damage, which is seen even in our common population. One was this, my point I wanted you to comment on it. And secondly, this ezetimibe, that previously it also came into market, and it was withdrawn because of the proposed risk of colon cancer, and yet we don't have any long-term data to support its safety against colon cancer, and even FDA is following a few long-term studies to see that whether it is perfectly safe or not. So I wanted your comment on this as well.
Thank you very much. I trust that you are a very experienced physician in Pakistan. You know your patients. You know whether they tolerate statin or not. I cannot comment specifically on that. I trust your good experience. The only thing I know is this sub-study from Hope Free, as I showed to you, with less side effect in the Asian patients. However, they came from different countries in Asia. My only solution to this is to try to find the appropriate dosage of statin and use combination treatment if you cannot reach a high statin dosage, because combination treatment is similar to hypertension control. You can reach goals with lower dosages in combination. But in the end, you are the responsible physician. You have to find the best solution. Your second question was about the risk of cancer. Of course, every drug sooner or later is accused of causing cancer. That was the case for statins, that was the case for insulin, for many of the antihypertensive drugs. So every widely used drugs will sooner or later be accused of causing cancer. And the argument is that we do not have enough long-term follow-up studies. My counter-argument is that the first large-scale statin trial was the 4S trial in 1994, and during long-term follow-up, there was no indication of increased cancer. You should look for total cancer, not specific cancer, because in theory, it might be so that a specific drug might increase some cancers but lower the risk of other cancers. So the only reasonable endpoint to me during follow-up is total cancer, total cancer. And for the statins, there is no indication that long-term treatment will provoke the risk of total cancer versus placebo, even if details have been discussed. For ezetimibe, there have been some discussions, I know, but according to the guidelines, at least there is no such long-term risk of cancer linked to ezetimibe. I always welcome further studies. I always welcome observational studies. But you know, the highest degree of evidence we have with the randomized controlled trials. And I'm not aware of any randomized controlled trial or follow-up study to really show any effect at all of ezetimibe on cancer. Do you have any other evidence yourself?
Thank you so much.
Thank you so much. Thank you so much. Thank you.
Had you been here, there would have been more question and answer session, and as people want to ask more and more questions, we are getting late for the next session. Thank you so much. Now,
Thank you for listening to me. I'm also willing to share all my slides. They are free for you. You can get it from the organizers. So all my slides are free for you if you want them. Thank you and goodbye.